Welcome to see you all today online. And as Nelson have mentioned, today's lecture will be divided into two separate parts. The first part will be a presentation by Professor Sam, and the second part will be a COVID update. And actually, the Hong Kong Dental Association plans to have a very regular online COVID update to all our members. And preliminarily, we plan to do it like a 2 weeks interval. And Heston, in the past 2 weeks, Heston have already delivered one of the COVID updates, and we found it very useful, and a lot of members have showed their interest that we, HKDA, should show more support and also give them more update COVID information regarding the government policies and also the problems that they encountered when seeing patients and also regarding their staffs. For the first part of the lecture, it is really our honor and pleasure to have Professor Sam as our speaker tonight, for him to share his expertise on the topic of the pandemics, past, present, and the future, their impact on dental care. Professor Sam is a renowned clinical academic with expertise in microbiology, infection, and also the senior executive at administration and dental education. He has served for over 13 years as the executive dean of dental schools, both in Hong Kong and in Australia. During the pandemic, he has authored over 25 widely cited articles on the subject. Professor Sam has received his exceptional King James for Professorship of the Royal College of Surgeons of Edinburgh and the Distinguished Scientist Award of IADR. He also holds concurrent visiting professorship appointments in over 7 international universities. He was recently appointed as the editor-in-chief of the International Dental Journal, the flagship journal of the FDI. Let us extend our warmest congratulations to Professor Sam on this recent appointment. May we now invite Professor Sam to deliver his presentation. Members who have questions may put forward their Q&A by typing into the chat box in the Zoom chat room, and we will back to the Q&A session after the presentation. Thank you very much. May I pass the time to Professor
Sam? Thank you very much. Can you all hear me? Yeah?
Yeah, clear. Thank you.
Okay. Good evening, everybody. And it's really a great pleasure for me to be back in Hong Kong and addressing all of you. I have done this so many times, and I have been a member of the HKDA and its scientific committee and served there. And it is actually an absolute shame. I was looking forward to meeting all of you soon, but well, you know, the pandemic put paid to those ideas. And so here we are today, and hopefully I will see you at another meeting soon when this is all over. Right, so let me, without further ado, thank the President, Dr. Nelson Wong, and for the invitation to do the presentation today, and also Dr. Senchari Chang, whom I know very well. He was a student when I was a dean, and for the kind introduction. So let's get on with our presentation, and let me share my screen, okay? So I believe all of you can see my screen, right? Yeah, yeah. So, so what we are going to do in the next 45 minutes is to talk about the pandemics, as was mentioned, past, present, and future, and their impact on dental care. So I would first like to, this is the outline of my presentation. And before that, I would like to say that, you know, 2 days ago, the 11th of March, was the second anniversary of the pandemic, the COVID being declared a pandemic. And so it's very, very unfortunate that this has happened. And so we are still in the various phases of the pandemic. And as you all know, we are on the 5th wave here in Hong Kong. So My outline is I'm just going to give you just a preamble on the historical aspects and the current wave, okay? Then talking about the past, why pandemics occur, right? Then I will talk about the pandemics and dentistry. How did we cope with this in the past and what we are doing now? And then I will looking into the final aspect is post-pandemic dentistry in terms of the new normal, which we are going to face in the future due to the endemicity of this organism into the future. So that is the outline of my presentation. Now, just to take you back, we went through another epidemic, not a pandemic, of SARS coronavirus infection in 2003. And then we went through that, and almost 299 people died from that epidemic. Unfortunately, it came to a close for some reason or another. We do not know why it happened, but there you are. So at that time, I wrote this article with Professor Malik Piris, who is a compatriot of mine, on severe acute respiratory syndrome and dentistry, a retrospective view. And in that article, we mentioned the dental community cannot let down its guard and must be constantly aware of impending infectious threats in various guises, as well as recrudescence of the disease that may challenge the current infection control regimen. Now, this statement turned out to be very prescient in the sense that we now have this unfortunate, not an epidemic, now a pandemic, which is the world over, spreading the world over. And indeed, the editor of the JADA invited me to write a new article about the current pandemic. And in fact, my presentation today is a presentation which I have taken from my article, which I wrote in the last December issue of the JADA, and it's called The Pandemics, Past, Present, and Future, Their Impact on Dental Care. And if you want to get more details of this presentation, you can access this site, or I think it's actually free to access because they are COVID articles. Or if you can't access it, you can email me, and I'll give you my email at the address at the end. Now, let's talk about the current wave, which is the current situation in Hong Kong. A guy called Murray wrote a very, very nice article in Lancet last couple of months ago. And he's from Washington. It's called the IHME. It's an institute where they do global statistics on pandemics, rather on the COVID vaccine and COVID. And these are some of the statistics and predictions he has given us. And I thought at the very beginning, I would like to share with you, because you may, at the end, you may tend to forget this, because at the beginning, your attention is at the top level. Now, this Omicron wave, which is the fifth wave, which is the current wave all over the world, fifth in Hong Kong, is infecting 125 million a day in the world, and it's 10 times the peak of the Delta wave in April 2021. And also, he reckons, actually, according to the data, over 50% of the world is now infected with Omicron when they get the infection, right? And this is very, very important for us to realize. And the statistics from that institute in Washington is that the 40% of Omicron infections are asymptomatic. And this has very, very important implications for dentistry, or for that matter, for everybody, for anybody. Because, 40%, 4 in 10 people who get this virus, Omicron, is asymptomatic and walking around. And that's why we have to keep on wearing the face mask and so on and so forth. But this is also a very important thing which he mentioned. The death toll from Omicron is similar in most countries to a bad influenza season in the Northern Hemisphere. So I think we are coming to a situation where Omicron fortunately Omicron is overtaking the Delta variant, and it's becoming more and more like the flu, and therefore it's controllable. And as we can see later, as I will show you later, and as you know, the vaccines and various other medical measures can mitigate the effects of this virus, and people will not die, as we are seeing today in Hong Kong, unfortunately, because the most of the people, 90% of the people, almost 95, are unvaccinated. So if you come to Hong Kong, and the current reckoning is 25% of the Omicron population is infected, right? And also considering that 90% of the people have got the vaccine, roughly, which means that the fair proportion of us are now, fortunately, mitigating the effect of the virus, even if we get infected. And as far as I'm concerned, the peak has passed, and I'll show you a slide again to show you this. And this is the international the way the profile of the virus all over the world. But the COVID is now becoming endemic disease, and due to the emerging of these variants. So what is the strategy for the dental community looking into the future? And that's what we are going to discuss in the future. Now, in a few next 30 minutes or so. Now, these are statistics from this institution, IHME in Washington. Look at the Omicron wave and how it's peaking. It's a very, very steep wave, and it goes very high and comes back. And you can see South America, North America, Oceania. And unfortunately, East Asian numbers are going up. This was like 2 weeks ago, but it's coming down again. And I think this refers some to the Hong Kong as well. So going back to the lecture, let's talk about the history of the pandemics. Now, before that, I want to just show you, this is a slide from my textbook in Essential Microbiology. And you can see that these infections are all over the world, not COVID infection, but emerging infections are all the time there. So as a profession, we have to be aware of these new infections coming from all over the world, not only viral infection, but also bacterial infection. So that's a point I want to get across to you at the very beginning. Now, this is actually gives the timeline of deadly pandemics over the centuries. This is not the first time we have had these pandemics. It started like historically, there are accounts, even 240 BC, where you get the typhoid fever during the Han dynasty in China. It's this part of the world, Then we have the smallpox, the leprosy, the so-called Black Death in 1315 in Europe, where they say almost 70 to 80% of the people died in Europe, and then smallpox and so on and so forth. And then we coming to the more 1980s, which is the Spanish flu vaccine, which is this is more than about a century ago. That is the one which a lot of people can remember, and that actually killed apparently hundreds of millions in comparison to the few millions which we are seeing now. Because at that time, they did not have a vaccine or a quickly produced vaccine. Then we come to various other types of flus. I'm not going to go into details. Then we have the SARS-CoV coronavirus, our coronavirus in 2003, which the Hong Kong was really, really beaten by. And then coming up to the various variants here. This is the timeline. So we have been having these vaccines for over a long, long period, and this is nothing new. So let's look at the second, why pandemics occur. This is my outline, as you know. And Now, there are a lot of factors in occurring the emergence of the vaccine, or emergence of the pandemics. So what happened was in 1970s, there is this top body in US called the Institute of Medicine. Because of the various pandemics which were occurring, they got down a task force of top scientists and asked them to develop a white paper on why pandemics develops. So, and after that, they came up with this white paper, why pandemics develop. And let me take you very, very quickly through their white paper, the salient messages from that. So they gave 5 major factors for emergence of the new viruses and new bacterial infections which cause us infections and pandemics and epidemics. First is societal events. The second is the healthcare. The third is the human behavioral patterns. The fourth is the environmental changes. And finally, the microbial adaptation. Okay. So now this is look like Latin to you, which is not understandable, right? So let me take one by one very quickly and take you through all of these. Let's take the societal events. So some of the reasons they gave are the economic impoverishments and the population migration. This is the biggest mosquito we have in the world today, the air travel. You know, you can go from Hong Kong to Venezuela to Timbuktu to any other part of the world within 24 hours and taking your infections across any part of the world, right? So that is one of the biggest problems, as we know. Then war and civil conflicts. I don't have to tell you too much about it. Now we are having a war and you can see so many people are dying and then so many people are starving. And this is actually a real ground for the various viruses and various variants of the viruses to emerge. And this is the societal events, okay? Secondly, we have the healthcare. Healthcare, then new medical devices, people living for a long, long period on medical devices in hospitals, because these people used to die earlier. Now they live forever virtually on medical devices, and they are very, very susceptible to infections. Then we have organ and tissue transplantations. Again, because of the immune suppression associated with that, then you get more infections coming up. Immunosuppression for various other reasons. Then antibiotic abuse. And I was glad to see that in the introductory remarks, your chairman, the president was saying that there's a task force on antibiotic abuse, antibiotic use, and this is something which we as dentists should be very much aware of that. And these all lead to new infections and pandemics and epidemics. Then the human behavioral patterns are very, very important. This is the third thing. And these include the sexual promiscuity, injectable drug abuse, antibiotic abuse again, and the vaccine hesitancy. I emphasize this, and this is one of the reasons why a lot of people die now. And this is now the current pandemic is called the pandemic of the unvaccinated. And because of that, when they are unvaccinated, there is a fresh ground for these viruses to vary their molecular architecture and the new viruses, new variants to emerge. And I will show you this in a moment. What is the big problem we're having in the world today is the virus, the differential vaccine distribution in a global manner. And finally, environmental changes, deforestation, floods and drought, and the global warming, all these contribute to the emergence of the vaccine pandemic. So these are the reasons, the microbial adaptation is the final one. The fifth one, emergence, they emerge from the wild. And for example, the HIV, immunodeficiency virus, is thought to have come from monkeys in African region. And then changes in the virulence and the toxin production and development of drug resistance for microbial adaptation. So So these are the reasons why pandemics emerge. And if you look carefully in a historical account of the world history, we can see how the world has changed and why these drugs, these organisms are emerging to cause new diseases which we have never heard of. Okay. So how do viruses jump from animals to humans? And again, just a couple of slides on this, just to give you an idea. I'm sure most of you know, but so let's talk about, for example, the flu viruses. Here we are talking about the flu viruses coming from the avian flu, right? These ducks and chicken and have something called the avian flu. But this flu virus cannot directly infect the humans, but it has to undergo something called molecular reassortment. So how does this happen? This happens because a lot of, like, for example, if you take China, there are animal husbandry programs, or even the villages, they have ducks and pigs and humans and dogs and cats living together. So this is a great opportunity for the avian viruses, but although they cannot infect humans, they can infect pigs, right? So, and unfortunately, pigs are very vulnerable to infection with human flu viruses in this case. So what happens is the pig acts as a blending vessel, you know, the blender in your kitchen where you blend all your fruits. Similarly, the blending, this is a blending vessel. These are the reassortment of the virus to create, for example, in this case, human influenza virus, and then causing a totally unknown disease in ourselves. And this is the avian human pandemic reassortment virus. Okay. So very quickly, we know that the SARS came from the civet cats and crossed the species barrier because they were eaten by the humans, and then at that time infect a lot of medics. And here that SARS-CoV-2 is thought to be, and we are not still sure about this, although there was an article last week on Lancet saying that there is definitive data to indicate they originated from this called horseshoe nose-shaped bats in China. And they actually infected pangolins and then caused the species barrier. Pangolins are eaten and the humans get the infection. This is the way it's being thought to be crossed the species barrier. Coming back to today, I'm not going to go into details. We know the 460 million infected up to today, the COVID, over 6 million deaths. Fortunately, 60% of the world is fully vaccinated. And this is the virus. I don't have to go through this. I'm sure you are sick of this picture. The important thing is the spike glycoprotein, which latches onto the receptors on the human cells. And we have receptors in almost every organ in the body, including the oral cavity, the nose, the lungs, and you name it. We have receptors, so-called ACE receptors in the human body, in any eukaryotic human cell. And these are this is virus coming out from the human cells. These are the pictures, scanning electron micrographs from the University of Hong Kong. And we have to, at this juncture, admit the work done by Hong Kong U on this SARS-CoV-2, and it's a fantastic amount of work has been done. Now, Charles Darwin said something which is very important in this context about the variants. In the struggle for survival, the fittest win out at the expense of their rivals as they succeed in adapting themselves best to their environment. And this is exactly what happened in the case of COVID. Now, the Omicron variant is much more adaptable than the Delta variant. So it's overtaking the Delta variant, and the 90% of the infections are now Omicron. So it is possible that we get another variant from the Omicron, which would be much more adaptable. You are talking about now the subvariant of the sublineage, which is called BA.1, BA.2, and so on and so forth. So these are sublineages. And then at this juncture, I would like to tell about the new variant, which is called the Delta Cron, which is supposed to be a combination of the Delta variant and the Omicron variants. Now, fortunately, papers which came out 2 or 3 days ago say that their infectivity is as equivalent to Omicron, if not lesser than that. The reason is the Delta Cron variant, the backbone of the Delta Cron variant is comprised of the material from the Delta virus, and the spike proteins are composed of the Omicron variant. So it's virtually an Omicron variant, although it's a combination of the two. So this is a little bit of more data, which is very, very fresh off the press on this. Here we have the variants, alpha, beta, gamma, delta, and Omicron. Then here we, this lecture, I have to do it so many times. Next time there'll be a Delta Cron here. As I say, it's a combination of Delta and Omicron. And this one has a skeleton, the backbone of Delta and the outside spike protein of Omicron. And hopefully, early studies indicate that it is as equivalent in terms of spread of infection as Omicron. Now, this is something about the Omicron variant, which has 32 mutations on the spike protein and 10 mutations in the receptor binding mode protein. And it's about 8 to 10 times more infectious than the Delta. And that's why it's overtaking the other guys. Again, I don't want to go through the aerodynamics of SARS-CoV-2. The particles which are greater than 10 microns just fall apart. As dentists, we have to know this. I believe we know that. And how we acquire the infection. So having gone through that very, very fast, let's talk about pandemics and dentistry. How did we come here in terms of infection control, and what did we do in the previous pandemics? Now, here I want to take you through very, very quickly 3 slides here on how we came about. Some of you are very young to the profession, others are old like me, 100 years in this profession, doing various things. So this is the evolution of infection control in medicine and dentistry. First, we had in 1970s universal precautions. Then we had standard precautions. And now we have, because of Omicron, so-called droplet precautions and transmission-based precautions. Let me take you through this very, very quickly. Now, if you are young, you will not know this. I practiced dentistry with ungloved hands. We didn't wear gloves those days. This is 1960s. Ungloved hands, and you can see some of the examples here. And we didn't think twice when there's saliva on our hands and blood on our hands during surgical maneuvers, like even extractions or doing third molar surgery or any other surgery. However, in 1970s, the dentistry got a wake-up call, as well as medicine, all the surgical professionals. So came in the 70s with reports of a number of oral surgeons and dentists transmitting hepatitis B infection to some of their patients in the USA and UK because they are improper infection control practices, right? And as a result of this, then we had, then we came in the 1980s, 1982, 1983, 81 in particular, HIV infection brought the lapses in infection control dentistry into sharp focus. And particularly there was a case called Kimberly Bergalis, a lady who claimed that she acquired the HIV infection from her dentist called David Asia. So this is the People magazine. It was big publicity. It was in CNN. And then she went in front of the Congress and said, I got my infection from a dentist. And then the dentistry was right in the middle of the spotlight. And a lot of people didn't want to go to the dentist because of that. And although now it has been shown that the possibility was dismissed through various genetic studies of the viruses. But the damage done to the profession was irreparable in the sense that, we were at the sharp edge of this episode. And because of all these, infection control recommendations came into being. And we had to recognize, it was particularly from the Center for Disease Control, CDC in Atlanta, they promulgated that all patients attending a clinic, irrespective of their health status, could be infectious, whether they are healthy or not, because they can have infections which are very overt and infections which are covert, which can be seen. And then they declared universal precautions, to handle all patients as if they are infected. Then the second level infections came along a little bit later. It's because universal precautions were not adequate, and because it doesn't really cover the bloodborne infections. And this is called the standard precautions to reduce the spread of bloodborne infections to the hospitals and clinics, okay? So universal precautions and standard precautions. Now what happened was, together with standard precautions, they had an additional set of precautions at the time, which is called transmission-based precautions, or also called droplet precautions. And this was to reduce the risk of causing droplet aerosols and contact transmission of airborne and highly infectious diseases. At that time, they were talking about tuberculosis and, for example, vancomycin-resistant Staph aureus and similar diseases. Although, we didn't know about the viral infections at the time, they said that if a patient with TB and VRSA comes along, you need to take additional precautions, which are called transmission-based precautions. Now, currently, what we are doing now, these are the guidelines during the COVID era with additional modifications because of the high probability of aerosol transmission of SARS-CoV-2, which has been proved time and time again. Okay, so we have covered the historical aspects of why pandemics occur, how and what did we do in terms of infection control over the past 20, 30 years. Let me, in the final part of this presentation, 10 minutes or so, talk about post-pandemic dentistry. So we know that COVID-19 is becoming an endemic disease, okay? There is absolutely no doubt about that. Then what is the strategy of the dental community? Now, in my the article, which I will urge you to read to get a further idea of this, we have said there are 5 or 6 major factors affecting post-pandemic dentistry. So first is the COVID-19 vaccines and vaccinations. Second is the point-of-care diagnostics. Third is the teledentistry. The fourth is infection control, which has a whole rigmarole of subsets, for example, administrative controls and engineering controls. And finally, continuing education and pedagogy. And this is exactly what you are doing now, because in these pandemics and even after the pandemics or the epidemics, you have to be aware of what's happening in your environment in relation to the emerging infections. And this is very, very critical. And I'm not going to talk about this aspect anymore. So let me spend 5 minutes on the COVID-19 vaccines and vaccinations, because this is very, very important. And this is currently a discussion of high importance. Okay, so COVID-19 and vaccinations, few slides on this. Up to March this month, this is the phase 1, phase 2, phase 3, phase 2 trials, human trials. This is there's a vaccine tracker, WHO vaccine tracker. There are so many vaccine trackers. We have 9 approved vaccines so far. Now look at this. 44 vaccines are in large-scale efficacy trials. That means a phase 3, which is almost reaching the last approval stages by the CDC and various other authorities. So we will have more vaccines, hopefully more efficacious vaccines for COVID Omicron and so on and so forth. Now, what is important is if you take this is a very, very busy slide, but I can't go through this at this point. But if you take the currently available vaccine, Pfizer, Moderna, all these Sputnik, Sinovac, Novavax, I would like to look at this yellow column here. Prevention of hospitalization. When this slide was done, this is about 3 months ago, it's 100%, virtually 100% prevention. If you do not have other comorbidities, even with comorbidities, the death rate is extremely low. And if you're an average healthy person, and if you get 3 doses of the vaccine, and I emphasize 3 doses, I'll tell you why in a moment, then you are virtually protected from the infection. But remember, you can be a symptomless carrier of the organism. That is critical thing to remember. And then that is because you can get something called breakthrough infection. And I don't have time to go into the details, but when you are vaccinated, you get 2 types of immunity. One is called the sterilizing immunity, and the other one is called the effective immunity. Now, sterilizing immunity is when you have produced so much antibodies, then the virus cannot even touch you. The effective immunity is the antibody is very, very good, but the virus can still grow on your throat or in your basically on your throat, so you can be a spreader of the virus. So anyway, I don't have time to go into these ones. I need another lecture actually. So important thing is 3 doses of the vaccine gives you 99 to 100% protection. Look at this very, very latest data on vaccine effectiveness. Okay, I'll take you through very, very carefully. This one, sorry, because it's a little bit confusing. So if you are, this is at the bottom, and the x-axis is the months since the second dose. You see, some months since the second. So after the second dose, 1 month after, second 2 months, 6 months after, right? So then there's a break here. Then there's a booster here. This is a 3rd dose, okay, right? Now look at the, let's look at the Pfizer vaccine, which is the blue line, right? This is the effectiveness on the y-axis. So the effectiveness at the very beginning is, immediately after the second dose, this is like immediately after second dose, it's almost 90%, but it goes down to about 60%. But after the 2 weeks since booster, it goes up to 95%. So these are the newest data from millions of vaccine produced all over the world, vaccinated individuals. In the case of the blue one, which is AstraZeneca, again, 65, 44, and goes up to 93. And this one, which is the Moderna, they don't have statistics for this. You don't know statistics. But the important thing is the booster is very, very critical. So I would advise you, all of you, to get the booster as soon as possible, and not immediately after booster. 2 weeks after booster, you get full vaccination, full prevention efficacy of the vaccine. So these are very, very important slides. These slides, this information changes on a daily basis. But this is what I got last week from this IHME center. Okay. So this is very, very important slide for you to remember. Boosters are important. You can tell your patients, tell your dental team the importance of these. And then as we go along, this will go down again. So as I will show you in a moment, we might have to take 4th vaccine doses after 6 months or maybe even 1 year, because we are in the front line, we are in the professional front line. We are facing the patients every day, and a proportion of these patients are symptomless carriers of the virus. Now, I'm not going to scare you by this, but these are the factual things. Even if the virus does not, there are no infections, it will not completely disappear from the population, unless you are, extremely lucky for some reason, like SARS-CoV earlier, the one which is just disappeared. Nobody knows the reason why. Now, why do I say that at the beginning? I said for these vaccines, you can get emergence of the variants. It can be highly possible. Now look at this global vaccination data from the database I got yesterday. Now, green means 90% vaccinated. I hope all of you can see 80 to 90%. And these dark areas is 20%. Just look at the disparity, geographic disparity in the vaccine distribution. And this is the danger area. This is actually a bed of infection where the new viruses can emerge. And if you take a flight from South Africa, maybe Cape Town to Hong Kong, you can bring that variant here. See? So the vaccine, distribution, and not only the distribution from the distributing center to the arm of the people is very, very critically important. And this has to be realized by everybody involved. Of course, we as dentists cannot do too much about it. This is the province of the politicians and those who are doing vaccine distributions. And this map is a stark reminder that, we are not doing enough for this whole world. Unless everybody is protected, nobody is protected. I think you have heard this, right? So this is something which I wanted to tell everybody about, and you should know this as professionals. So let me give you some, after the little bit of bad news, something good news. Now there are new vaccines coming along in terms of like packed pills and also oral vaccines and nasal spray vaccines. So according to the databases, we have the nasal spray vaccines. There are about 14 clinical trials. I do not expect you to read these. And there we have. So you can go to this website, and there are some of them are in very early stages. What you do is you just take, like when you have a cold and you have stuffed nose, you have to spray your ephedrine or whatever into your nose. So you spray the vaccine into the nose, and the viruses start growing there to some extent. These are not this is not the real virus, but these are artificial viruses, but these can create antibodies, artificially created viruses, antibodies to COVID. This is the nasal spray vaccines. So the other one is, I don't know what happened to the other one. Just one minute. There should be another one, but the other one is the oral vaccines. Yeah, the oral vaccines. Here we are, oral COVID vaccines. There are about 4 or 5 coming up in various places, California and various other places. So these are the pill vaccines. So in the future, we'll have a lot of armamentarium to kill this virus and manage these infections. So that's a good news. So now, as I said, this is the pandemic of the unvaccinated. When you're taking this lecture by what I began, the implications for dentistry, we will have to take a vaccine once in COVID vaccines, maybe once in 6 months or once a year or so. So if you go back to that picture of ours, what's the future? Then another one is called the teledentistry. Again, I don't have time to go into this, but very briefly, we know that making physical contact with patients or pre-symptomatic people will be critical, and we need therefore teledentistry for these purposes: teleconsultations, telediagnosis, teletriage, and telemonitoring. So, and for these things, they are used, this is for remote consultations, for follow-up advice, assessment, pre-symptomatic exposure period. They will ask you about things, your oral conditions, post-recovery period, post-treatment period. So you need to have answers when patients ask questions. You say, I'm in the post-recovery period and I have a toothache, or I have an oral lesion, or I have something which I'm bothered. So you need to know about all this, what advice you would give. And also, the pre-existing oral diseases. Now, as I will show you later, the collateral damage is done here because our patients with cancers and various other conditions which require continuous rehabilitation, they do not come to the hospital. They do not go to the dentist because of the fear of infection, and these are also suffering. You know, for example, if there are oral lesions, which may be a precursor to a cancer, they may not go to that dentist for 6-7 months, and they become a fully blown cancer later on. So these are problems and which can be solved by teledentistry to some extent. And then point of care diagnosis coming into full swing just now. And all of you know that about this, about 450 now in the development stages. You know, these are diagnostic. When a patient comes in, immediately within 30 seconds, you can check. These are like lateral flow things. Even things are going to be much easier in the future. And the important thing is to have reliable, sensitive, and specific point of care diagnostic tests. And, you know, but we have to be positive. But I believe now this is done throughout the world, and also in dentistry. I know that it's done in Hong Kong, that in all the surgeries, you do lateral tests before you come to the, at least once a week or once a day or whatever, depending on the situation. So we have covered the vaccines, point of care diagnostics, and teledentistry. Let me just I have got a couple of slides on infection control. I covered this, and the slides are this slide actually. So again, I need to give you a full lecture on, or more than one lecture. You can write a book on this. There's a framework for COVID-19 control in dental practice, starting with planning protocols, patient screening, preparing facilities, PPE and infection control procedures, and aerosol control. So I'm sure the HKDA has had lectures on this, and they have guidelines for HKDA. So you should please follow these guidelines, and they should be updated at least on a monthly basis, because things are changing so fast. And then you have the various precautions, the transmission-based precautions on this side, and the hierarchy of controls in terms of engineering controls and administrative controls, so the COVID has really turned the dental services upside down in terms of the infection control, which is very, very critical. You are talking about the health of yourself, your family, your assistants, your secretaries, and everybody else who work there. So these are very, very important issues. So some predictions of the future. Let me just take you through the last 4 slides. Now, as I said, COVID is here to stay. We can't get out of it. Very, very unfortunate. And I don't like it, because I have been stuck in Hong Kong after coming from Dubai for the last 2 years. I can't do any. I do all my lectures like this on Zoom lectures, and I don't like it either. So nobody likes it, but that's where you are. And the current pandemic situation in Hong Kong is very, very sad. And I hope it's going to end soon, because as I said, the peak has passed. From my readings, I know that they come down very quickly, because the virus has infected about 25% of the population. 90% have got the vaccine. So the virus has nobody to infect within the next couple of months, I believe. So let's hope this will be true. So, so these are some of the predictions. COVID-19 will continue as a pandemic in one or more regions. You saw the the African region. That's a big problem area. It will be endemic in most regions, right? Always present but transmitted among people at predictable rates. Now, we are talking about the herd immunity. Earlier, they said if 80% of the people are vaccinated, 75 to 80%, this is in relation to other diseases like measles, mumps, and various other diseases, previous diseases. If 80% of the population vaccinated, they do not spread. But now for COVID, it's 90%. Now it's kind of gone up. So the people are asking, what is this herd immunity? Is it true or not? So if you can take some guides from our 1918 influenza pandemic, which killed millions, they say 100 million people. I don't know whether they are true or not. But after 104 years, the influenza virus, the seasonal influenza, is derived from H1N1, this original strain. in various guises, so almost influenza A infections since 1918 have descended from that stream. So we can get a cue from that virus. So it will be with us, but we have effective vaccines for influenza. I believe all of you take vaccines every year as professionals in our vaccine armamentarium, measles, mumps, rubella, hepatitis B, influenza, and so on and so forth. So there are questions. Will COVID lead to higher rates of long-term complications than diseases such as influenza and CME? We still don't know the complications. There are various stories floating around, and the most popular one just now is that it shrinks your brain and your memory kind of goes for down. But I don't know whether it's related to Omicron because Omicron has been there with us only for 6 months. Routine testing actually for the professional might become a part of everyday life. So COVID positive people with, these are symptomless people who like to wear masks and isolate from others. Society could end up even safer against infectious respiratory. So all of you may have realized for the last couple of years, we have not got the common cold as frequently as before, right? So actually COVID has, if there is only one silver stream in this, this dark cloud, that is the only positive thing. We haven't got these nasty colds and other influenza flu-like infections because we are taking precautions. So, so we have come to the end. So we've covered the take-home messages, historical aspects. We know now why pandemics occur, transmission from animals to humans, and how we arrived at our infection control, and some aspects of post-pandemic dentistry, including teledentistry, vaccination, pedagogy, infection control, and so on and so forth. So just my last slide, infection control is paramount. I don't have to tell you that. Annual or 6-monthly COVID vaccination is highly, highly likely. And good thing could be that it could be the vaccine could be a combination of COVID-19 and the influenza A, the common influenza, seasonal influenza. So people are developing this kind of vaccines. Routine testing is going to be a permanent feature, particularly in endemic areas. So you know that the Ebola virus is simmering in Asia, but sometimes you say, okay, there's Ebola infection coming up. So these are endemicity of the organisms. So we hopefully, I don't know, hopefully Hong Kong will not become an endemic area for this. And routine testing is going to be permanent. And the other things, they are the damage, collateral damage. The patient costs will go up because our infection control, rigmarole infection controls really adding up to the cost of treating each patient. But here, I think it's very, very important that sustainability and so-called green dentistry will have to play a key role in infection control. We have to think of the environment, and we should not go overboard. There's an optimum point at which infection control is effective, beyond which how many masks you wear, or 10 masks you wear, or different things you do, is not going to prevent the infection more than the optimum, So that is something which you have to consider. So as I said earlier, the collateral damage due to neglected oral diseases, and this is something which nobody has compounded. And now we are getting, as I said, I'm the editor now in the IDJ. I'm getting some papers about this subject, how people have neglected their oral diseases during the last 2 years, and some case presentations and so on and so forth. So with this, I would like to end my presentation. I would like to thank you again for being with me for the last 1 hour or so. And also, I would like to thank the President, Dr. Nelson Wong, for the kind invitation, and also the HKDA committee. And I know I may have gone over the line, but I'm happy to answer any questions if there is. Thank you very much.
Thank you very much, Prof. Sam.
Yeah.
Thank you very much for your impressive lecture tonight. And we know we all dental colleagues are practicing very good infection control, and we really appreciate that all your work in your research and also your efforts in making this protocol more robust in different tiers of pandemics throughout these years. And actually, I think that we have some questions in the chat room, right? And also, if anyone want to raise any question, please feel free to speak out. Since we didn't receive any question in the chat room, maybe Michael, you have got a question to ask Prof, right?
Okay, hi Prof. I'm Michael. Yeah, really nice to meet you in this platform.
Yeah, thank you, thank you.
My question is that what's your preference? What's your preference in choosing the vaccine? Because there's two types of vaccine in Hong Kong. One is Sinovac, another is BioNTech.
This has become a politics. Yeah, as a scientist, I don't want to get into politics of it. As I demonstrated in that slide, which I got it 2 weeks ago, the Pfizer vaccine actually beats everything else, even better than Moderna. So I would go for Pfizer if you have the opportunity. And something which I forgot to mention, which is so-called heterologous vaccination. So if you have 2 Sinovacs, the third one could be Pfizer, and that actually boosts up your immunity quite high, gives you a very high immunity as well. So I would like to say that if you have got 2 Sinovacs, unfortunately the Sinovac, the immunity level, you see, the other thing I want to tell you is that all these vaccines are very, very efficacious if you consider the flu vaccines. The efficacy of the current flu vaccines is almost about 55 to 65%. Now, all the current vaccines for COVID, their efficacy ranges from 70 to 90%. So the COVID vaccines are far better than the flu vaccines. So I just want to give you a benchmark. So if you are considering that benchmark, all the vaccines are good. So of the current COVID vaccine, which is the best? Pfizer. So if you take Pfizer also, if you have taken 2 Sinovac actually is bottom in the league in terms of the antibody production, in terms of these 4 vaccines. But the range is like from 60 to 90%, but that's quite a big range. So I'm asking you, if you are taken 2 vaccines of Sinovac, then take the 3rd vaccine, if at all possible, the Pfizer vaccine, right? So you can mix and match these vaccines. And it has been shown time and time again, then this is good. So bottom line is my preference is Pfizer, but if you have taken Sinovac, go for a 3rd booster dose for booster Pfizer, and hopefully 6 months later or 9 months later, if we have to continue, I am sure 110% sure we will have to do this. So try to go for Pfizer. Thank you very much for the question.
Thank you, Prof. There's a question, yeah, maybe I give back to Century.
Yeah, back from the chat room, we have a question from Dr. Patrick Wu. And Dr. Wu have mentioned that can Prof enlighten us and give us some information concerning about long COVID?
Yeah, so yeah, that's a very good question. Yeah, so the long COVID was now, as we know, we have been having this pandemic for the last 2 years. Quite a number of, I think it's about 10% of the population who got the COVID have this syndrome called long COVID, which is constant tiredness and inability to concentrate, and also some other, like sometimes chronic diarrhea and stuff like that. There's a number of things, and also mental confusion and mental fussiness. And so these are some of the things which associate with Delta. Now, the Omicron variant is with us for the last 1 year or so. So with the Omicron variant, apparently, I saw a few news articles saying that the long COVID syndrome is lesser with the Omicron variant. So that may be good news. So this is what it is. Yeah. So long COVID is that. Thank you for that question.
So thank you very much, Prof. And we have another question from Dr. Derek Barham. And he would like to know, are those adjuncts like the air filters, the HEPA filter, the UV lights, the high volume suction, the face shield recommended for the current dental practice infection control protocols? Because during SARS, the second question is that during SARS, the ratio of 1 to 99 bleaching solution dilution was recommended. And what is the recommendation now? And should we use alcohol or diluted bleach to disinfect the clinical services?
Yeah, I can see this question. Thank you, Dr. Barham, for that. So now air filters are critical, for every surgery. And I think you need to use if at all possible, you have to retrofit with HEPA type air filters, high efficiency particulate filters. And there comes in various sizes and shapes I believe, for surgeries as well as hospitals and so on and so forth. And also, if you are building a new surgery, this one of the very important things you have to consider now is how you should fit your surgery to fit the future, as it were. Because these viruses, you never know what the next one is going to be. We had within 2003, we had SARS. Now we have 2020, we had this one. In 10 years later, we might get another one. I don't want to predict this, but unfortunately, that's what it is with what is happening now in the world, world wars, environmental pollution, heating and so on. So I'm going back to air filters. Air filters are good. It must be used if at all possible. But I don't know whether the current surgeries can retrofit it with HEPA filters. I don't know the manufacturing standards and the qualities associated with. So now the UV lights actually, some surgeries have UV lights overnight. Now, if you are doing proper disinfection, I think UV light is optional thing, optional accessory, as it were. But on the other hand, if you UV lights, I don't think that's very expensive. So lots of surgeries, I know dental schools in Saudi Arabia and various places and UAE, we have UV lights fitted to every surgery. And of course, it's going to cost electricity. But at night, once you finish, you put it on and then just keep it on. So it does actually kill viruses. So that's good. High volume suction, yes, I have to say that you have to use it. So all these face shields are, I mean, if you are using N95 mask, why do you want to have a face shield on top of it? And number one, it's very, very uncomfortable. Number two, it's probably optional requirement. Because as I say, you are spending too much on infection control. I mean, there is a plateau. Once you come to that plateau, however much you spend, you will not increase the efficacy. So, and particularly if everybody in the surgery is vaccinated properly, and I believe most of you are healthy, have no essential major comorbidities, then I don't think, additional, all these one on top of each other, face shield in front of an N95 mask is essential. But some of these are essential, but you need to get the balance right. And so that's very, very important. And the other thing, Dr. Barham, is that, the endemicity of the virus, we don't know how long. Now we are going to go for a zero COVID, and I don't know how this zero COVID principle is going to last in Hong Kong or in China. And if it's zero COVID, then that's so much expenditure on infection control is just absolute waste of time, a waste of money, as well as environmental pollution through infection control. Things like PPE it's supposed to be, I saw some pictures where, all these have been put in rubbish bins, and it's unbelievable. So, and with regard to the second question, should you use alcohol or diluted bleach to disinfect clinical surfaces? Now, clinical surfaces, if you use bleach, you can use bleach. The dilution, I just forget the percentages. But the problem is bleach, if it touches any metal surfaces, it tends to crack. And that over a long term, when these cracks and crevices and corrosion will be surfaces for retaining all the bacteria and viruses and whatever. You can't clean them properly. So I would go for the alcohol rather than bleach in this instance. Thank you.
Thank you very much, Prof. And also thank you for questions from Darren and also Dr. Wu. Maybe we cut it this time tonight because we are actually really running out of time for the part one. And the President asked the last questions that maybe you have some concern about medicine of COVID, the new medicine, the antiviral medicine.
Yeah. What's that?
Yeah.
We know that there is some new medicine for the antivirus for the COVID. May I have your opinion about that?
Yeah. So the new medicine. New medicine. There are two major ones, which one's called Foxlovid and the other one's called Melpunavir or something. It's quite a very difficult name to pronounce. These two both are very, very effective, but the efficacy, for all viral infections, we say, if you can recall my microbiology classes, when you have a herpetic infection, it's no point giving the Zovirax or all the ointments, acyclovir, once the blister comes up, right? So we'll have to give the patient the antiviral during the initial itching stages of the let's say the lip. So same principle applies here. If you give them early, if you catch them early, so in the very early phase, when you get a viral COVID infection, very early phase, when you are, let's say your lateral flow is positive and your RAT is positive, you have to get these one of these, or one or two of one actually, Foxlovid or the other Melpunavir. They are very, very effective. They are antivirals, which is like antivirals against HIV, which prevents the infecting the virus. So they are very, very effective. So it's been proven. But the important thing is when it comes to the final stages, like when severe infection, large stages, they are not effective. But by that time, the virus has latched onto most of your organs, and it can create, dysfunction. Thank you for that, Dr. Wang.
Thank you. We have one extra question.
We got one question from Dr. Eric Leung. Yeah, his question is that we know that from some studies that the viral content in the saliva will be high initially. Yeah, therefore, will it be useful that for us to add saliva into our solution of the test kit for the nasal swab so that we can have a more accurate result? Do you recommend this kind of practice, or maybe just it should be using with the saliva kit to test the COVID? Yeah.
Yeah, it's a very innovative way of thinking. But I don't think the manufacturer, I'm afraid, sorry for that. Thank you for Dr. Leung for that question. Very innovative, but I don't think it's a saliva actually will give you a, saliva is saliva. You get so many different types. You can get whole saliva, which is too diluted, or you can get parotid saliva. So it will be very inconsistent, irregular, insensitive, and non-specific. So therefore, just stick to the regime and where the manufacturers say what they have to do. And I know people have been trying this kind of things, and they do not recommend going beyond what is recommended. So that's my answer, and that's the proper thing to do. So saliva, yeah, it could be easily used, and in the future, I was talking about point of care tests. Saliva will be much better than, not better, it will be used easily, because if the sensitivity of the test kits increase, then we can use saliva very quickly to do a quick test rather than swabbing and very, very uncomfortable swabbing, and kids don't like it, and saliva is easily accessible. So thank you for that question, and thank you for that. One
follow-up question is that in the market, now there are few brands of the RAT kits is using saliva as a test kit. Do you think that at this moment, the saliva test kit will be an accurate one as other nasal swab kits available?
Yeah, there are so many. I told you, I can't remember the numbers. There are so many of the point of care tests coming up, and the quality control is very, very different. So, and some of them are actually fake. So you have to I cannot say whatever, of course, saliva is useful indicator of the presence of COVID because the COVID latches onto mucosal cells on the oral cavity. In fact, the mouth is the first, apart from the nose and the mouth is the place where the infection can get in and they latches on there. So saliva is very good, but salivary test kits, depending on their sensitivity and specificity, if you want to use that, then I would first look at the specificity and the sensitivity and the manufacturer. So there are test kits and there are test kits, and some of them are good and some of them are not so good. So I would like to, that's my opinion on that.
Oh, thank you very much for your answers. Yeah, thank you, Prof. Yeah.
Thank you. Thank you.
Thank you very much for everybody. Really love to meet you soon. Let's hope so.
Yeah. Unfortunately, we have to see each other online now, but we're really looking forward to the next meet up with physical attendance. Thank you very much for your lecture and stay healthy. Yeah.
No, it's no.
Thanks, Prof. Bye.
Thank you.
Bye.